This is the start of Chapter 3, Clinical Approach to Ocular Surface Disease, from the BCSC Cornea External Disease chapter. The chapter provides a structured framework for evaluating and diagnosing disorders affecting the ocular surface. Let's get started. This slide summarizes the clinical features of papillae, which are localized, elevated conjunctival lesions characterized by a central vascular core, best appreciated on the upper eyelid. Papillae are commonly associated with bacterial and allergic conjunctivitis. The presentation varies based on the severity and duration of inflammation. In acute or mild reactions, the papillae appear smooth and velvety, as seen in Figure A. In contrast, chronic reactions result in elevated, polygonal hyperemic mounds with a central red dot, representing a dilated capillary core, seen in Figure B. Giant papillae arise from prolonged or severe inflammation, particularly in chronic allergic conditions. They are defined as being greater than 0.3 millimeters in diameter, seen Figure C, and may show furrows that trap mucus or pus. Following resolution, fibrotic subepithelial stars may form at their apex, Figure D, leaving visible sequelae of prior inflammation. This slide outlines the key features of follicles and follicular conjunctivitis. Follicles are round conjunctival lesions composed of lymphocyte clusters that are surrounded by blood vessels. They lack the central vascular core that is seen in papillae. Follicles are best visualized in the lower fornix and are typically associated with viral conjunctivitis. Follicular conjunctivitis presents with conjunctival injection, new or enlarged follicles, and visible surrounding vasculature. These lesions are especially notable in the palpebral conjunctiva and may occasionally appear on the bulbar or limbal conjunctiva. A special variant, benign lymphoid folliculosis, refers to non-inflamed, enlarged follicles commonly found in the inferior conjunctiva of children and adolescents. Importantly, follicles are absent in neonates, as their immune system is not yet mature enough to mount a lymphoid response. This is a figure that depicts the differences between papillae and follicles. Papillae, as seen on the left, are elevated conjunctival lesions with a central vascular core, appearing clinically as red dots in its center. They are anchored to the tarsus by fibrous septa and contain inflammatory cells like neutrophils and lymphocytes. Papillae are typically seen in allergic or bacterial conjunctivitis. In contrast, follicles, as seen on the right, are pale, translucent nodules made of lymphocytes and mononuclear cells, with no central vessel. Vessels lie beneath the lesion. They are found deeper in the conjunctiva and are characteristic of viral or chlamydial conjunctivitis, representing lymphoid hyperplasia. In summary, papillae are vascular and inflammatory, while follicles are avascular and lymphoid. This slide introduces keratitis, which is inflammation of the cornea. Keratitis is defined by several clinical descriptors. For instance, distribution. It can present in a diffuse pattern, localized or focal, or with multiple foci or multifocal. Depth. Inflammation may affect various layers, including the epithelial, subepithelial, anterior stromal, deep stromal, or endothelial layers. Location. Lesions may occur centrally, paracentrally, or peripherally. Shape. Common morphological patterns include dendritic, disciform, and geographic configurations. The accompanying Table 3.3 lists corneal findings and their associated differential diagnoses, such as endothelial keratitis, often linked to immune rejection, HSV or VZV, peripheral keratitis, seen with marginal infiltrates or autoimmune disorders, punctate epithelial erosions related to dry eye or toxic reactions, punctate epithelial keratitis, commonly associated with adenovirus or herpes, stromal keratitis differentiated into non-suppurative, such as acanthamoeba or autoimmune disorders, and suppurative, such as bacterial, fungal, or trauma-related. This comprehensive overview supports clinicians in characterizing keratitis to narrow the differential diagnosis and guide appropriate management. Epithelial inflammation of the cornea, punctate keratitis, is a nonspecific term that encompasses a variety of biomicroscopic inflammatory changes affecting the corneal epithelium. Punctate epithelial erosions, or PEEs, are small epithelial surface defects that stain positively with fluorescein dye. These erosions are seen in numerous inflammatory conditions and represent true breaches in the epithelial surface. Punctate epithelial keratitis, or PEKs, which consists of small epithelial lesions that do not stain with fluorescein. These are commonly associated with Digestion's epithelial keratitis and herpes zoster keratitis. A key clinical distinction between the two lies in their staining properties and underlying pathology, as illustrated in Figure 3.6, which compares the structural appearance of PEEs and PEKs. This slide introduces stromal inflammation, also known as stromal keratitis. Inflammatory cells can enter the corneal stroma through three main routes: from the tear film via an epithelial defect or directly between stromal layers, such as after LASIK; from the aqueous humor, particularly when there's endothelial injury; or from infiltrating blood or lymphatic vessels in a vascularized cornea. We can characterize stromal inflammation by several features: the degree of inflammation, whether it's suppurative or non-suppurative; its distribution, focal or multifocal; location, central, paracentral, or peripheral; and the depth, whether subepithelial, anterior, or deep stromal. Stromal inflammation often leads to corneal opacification, which results from disorganized collagen fibers or deposition of substances like calcium, lipid, or proteinaceous material. In some cases, we may also see dark pigmentation caused by retained melanin or iron salts. Finally, stromal inflammation can lead to neovascularization. This can manifest as pannus, with subepithelial fibrosis and new vessels that may penetrate deeper corneal layers depending on the stimulus. This slide shows a variety of clinical appearances of stromal inflammation or stromal keratitis. In image A, we see suppurative keratitis, characterized by intense inflammation and stromal infiltration, often with an overlying epithelial defect and a hypopyon. Image B displays non-suppurative, non-necrotizing stromal keratitis, also called disciform keratitis. This is typically immune-mediated, with stromal edema and minimal infiltrate. In C, there's an immune ring, a classic sign of antigen-antibody complex deposition within the cornea, commonly seen in response to infections like acanthamoeba. Image D illustrates peripheral ulcerative keratitis. Note the ovoid area of stromal thinning in the inferonasal quadrant, which may progress rapidly and is often associated with systemic autoimmune disease. Finally, on the right, we see a close-up of corneal pannus, which refers to superficial neovascularization overlying the cornea. This can result from chronic inflammation or hypoxia and may lead to scarring and vision loss if it progresses. These photos highlight the diversity of stromal keratitis presentations and the importance of recognizing underlying causes to guide management. This slide covers endothelial inflammation, which refers to dysfunction of the corneal endothelium that leads to epithelial or stromal edema. This occurs when the endothelium can no longer maintain its normal barrier and pump functions, resulting in endothelial decompensation. A key feature is the presence of inflammatory pseudogutae, which are swollen endothelial cells. These appear as dark spots when viewed using specular reflection and should not be confused with true gutae seen in conditions like Fuchs dystrophy. We also look for KPs. These are clumps of inflammatory cells deposited on the corneal endothelium due to leakage from the iris vasculature. KPs can take several forms depending on the predominant cell type. Fibrin or proteins appear as fine dots and strands. Neutrophils and lymphocytes form small, punctate, round, or stellate opacities. Macrophages produce large, greasy-looking clumps known as mutton fat KPs. When KPs are accompanied by focal stromal edema, it suggests a deeper inflammatory process. This is often seen in disciform keratitis from herpes simplex or zoster, endothelial graft rejection, or fungal keratitis, where fibrin plaques may form on the endothelium, suggesting that the infection has breached through Descemet's membrane. Let's change course and begin our discussion on dry eye. Dry eye is a multifactorial disease of the ocular surface, characterized by tear film instability, inflammation, and neurosensory dysfunction. Its etiology includes tear film instability and hyperosmolarity, ocular surface inflammation and damage, as well as neurosensory abnormalities. Pathophysiologically, it stems from disturbances within the lacrimal functional unit, which encompasses the lacrimal glands, ocular surface, eyelids, and associated nerves. Demographically, dry eye becomes more prevalent with age, affecting about 10% of individuals aged 30 to 60 and up to 15% of those older than 65. It is more commonly observed in women, but there is no known racial or ethnic predisposition. Dry eye is a multifactorial condition in which tear hyperosmolarity plays a central role by stressing the ocular surface epithelium. This stress triggers the release of inflammatory mediators that disrupt the tight junctions between superficial epithelial cells. As the inflammation progresses, T cells infiltrate the epithelium and release pro-inflammatory cytokines such as TNF-alpha and IL-1. These cytokines further accelerate epithelial cell detachment and program cell death or apoptosis, causing additional junctional damage and attracting more inflammatory cells. Ultimately, this cascade results in a self-perpetuating cycle of inflammation that underlies the chronic nature of dry eye disease. This diagram illustrates the complex interplay of inflammatory mediators in dry eye disease, highlighting both aqueous-deficient dry eye and evaporative dry eye. In aqueous-deficient dry eye, factors such as aging, autoimmune diseases, systemic drugs, and reflex block impair lacrimal secretion, resulting in low tear flow and increased tear osmolarity. In evaporative dry eye, environmental stressors like low humidity, wind, and heat, as well as MGD, increase tear evaporation, similarly raising tear osmolarity. Elevated osmolarity activates intracellular signaling cascades, MAP kinase, NF-κB, leading to the production of pro-inflammatory cytokines, IL-1, IL-17, interferon gamma, TNF-alpha, and matrix metalloproteinases, or MMPs. These mediators damage epithelial cells and goblet cells, disrupt mucin production, and promote apoptosis and surface stress. This damage compromises tear film integrity, further increasing osmolarity and perpetuating the inflammatory cycle. Compensatory responses such as increased blink rate and reflex tearing attempt to mitigate symptoms. However, ongoing friction, vitamin A deficiency, preservatives, and contact lens wear exacerbate surface damage. Ultimately, both aqueous-deficient dry eye and evaporative dry eye converge on the same pathophysiological cycle of tear film instability and chronic ocular surface inflammation. As previously mentioned, dry eye disease is classified into two primary categories: aqueous tear deficiency and evaporative dry eye. Aqueous tear deficiency results from T-cell-mediated inflammation of the lacrimal glands, which leads to decreased tear production and an increase in inflammatory mediators. In contrast, evaporative dry eye primarily involves MGD, where altered lipid metabolism, specifically a shift from unsaturated to saturated fats, leads to gland obstruction. This dysfunction causes increased tear evaporation, resulting in tear film instability and tear hyperosmolarity. It is important to note that many patients exhibit features of both categories, highlighting the multifactorial nature of dry eye disease. This chart depicts common etiologies of dry eye within the two major categories, aqueous deficient and evaporative. Aqueous deficient dry eye is characterized by inadequate tear production, either due to Sjogren's syndrome, which is an autoimmune condition affecting the lacrimal glands, classified as primary, or non-Sjogren causes, which include lacrimal gland deficiency, lacrimal duct obstruction, impaired reflex secretion, and the influence of systemic medications, such as antihistamines, beta blockers, and certain psychotropics. These conditions ultimately lead to reduced tear volume and an unstable tear film. On the other hand, evaporative dry eye occurs despite normal tear production and is further divided into intrinsic and extrinsic subtypes. Intrinsic factors include MGD, disorders affecting the eyelid aperture, decreased blink rate, and side effects from medications like isotretinoin. Extrinsic factors contribute to tear film instability and include vitamin A deficiency, topical drug toxicity, particularly preservatives and eye drops, contact lens wear, and ocular surface diseases such as allergic conjunctivitis. Environmental influences such as low humidity, high wind speed, and high ambient temperatures, as well as behavioral factors like wide palpebral fissure or decreased blink frequency, can exacerbate both forms of dry eye. These internal and external contributors often overlap, and many patients present with features of both aqueous deficient and evaporative dry eye, emphasizing the multifactorial nature of this condition. Several factors contribute to tear film instability, each potentially exacerbating or triggering dry eye symptoms. Ocular allergy and contact lens use can disrupt the ocular surface and tear composition, leading to irritation and inflammation. A high dietary omega-6 to omega-3 fatty acid ratio may promote systemic inflammation, further impacting tear film quality. Systemic conditions such as diabetes and behaviors like cigarette smoking also impair tear production and increase oxidative stress on the ocular surface. Additionally, prolonged screen time or sustained upward gaze reduces blink frequency, decreasing tear film renewal and promoting evaporation. Environmental dryness, including exposure to air conditioning and low humidity, significantly increases tear evaporation and instability. The long-term use of preserved topical ocular medications can damage the epithelial surface and alter tear film dynamics. Lastly, xerophthalmia, typically due to vitamin A deficiency, directly affects the mucin layer of the tear film, compromising its stability and protective function. Neurogenic and structural mechanisms play a critical role in the pathophysiology of dry eye. Corneal nerve stimulation arises when epithelial injury triggers discomfort, increased blinking, and reflex tearing. When mucins are lost, friction on the ocular surface increases, which further stimulates corneal nerves and can lead to neurogenic inflammation of the lacrimal gland. This inflammation exacerbates tear instability and perpetuates symptoms. Impaired tear delivery occurs when conjunctival scarring or sensory nerve damage diminishes the reflex arc responsible for tear secretion. As a result, the ability to produce reflex tears in response to irritation is reduced, worsening ocular dryness and discomfort. Several common triggers contribute to these neurogenic and structural changes. These include LASIK and PRK surgeries, which can damage corneal nerves, long-term contact lens wear, which alters corneal sensitivity, and chronic use of topical anesthetics, which can impair normal neural feedback mechanisms. Addressing these underlying contributors is essential for comprehensive dry eye management. Aqueous tear deficiency presents with a range of symptoms, including burning, itching, dryness, and a gritty or sandy sensation in the eyes. Patients may report sticky discharge, photophobia, and blurred vision that sometimes improves with blinking. Symptoms typically worsen as the day progresses or during sustained visual tasks, particularly in environments with wind or low humidity. A key clinical insight is that mucus discharge, which is common in moderate to severe cases of aqueous tear deficiency, can mimic infectious conjunctivitis. Similarly, the itching experienced by patients may be mistaken for allergic conjunctivitis, making accurate diagnosis essential. Clinical signs of aqueous tear deficiency include bulbar injection and a decreased tear meniscus height, which indicates reduced tear volume. The corneal surface may appear irregular, and tear film debris or mucus may be present. Additional findings can include punctate keratopathy and filamentary keratitis, both of which reflect underlying epithelial compromise and inflammation due to tear deficiency. The diagnostic evaluation of aqueous tear deficiency relies on both functional tear tests and detailed slit lamp examination. The Schirmer test measures tear production, with values of 10 millimeters or more considered normal, and values under 5 millimeters indicating tear deficiency consistent with ATD. Another key assessment is tear breakup time, or T-BUT, which evaluates tear film stability. A T-BUT of less than 10 seconds reflects rapid tear film degradation, a hallmark of instability seen in ATD. During slit lamp examination, findings suggestive of ATD include a reduced inferior tear meniscus height, typically measuring less than 1.0 millimeters, indicating diminished tear volume. Additionally, epithelial keratopathy may be present, manifesting as fine, granular, or coarse inconfluent staining patterns on the corneal surface. To further assess ocular surface damage, vital dye staining is utilized. Fluorescein stains areas of epithelial disruption, while rose bangle and lissamine green are more specific for devitalized epithelial cells and mucus. These stains are especially helpful in evaluating conjunctival health, particularly in the nasal and temporal limbus and mid-peripheral cornea. Together, these tests provide a comprehensive evaluation of tear film quality, ocular surface integrity, and the severity of aqueous tear deficiency. In advanced stages of ocular surface disease, several distinct features and complications may emerge. One hallmark is the presence of filaments, which are composed of degenerating epithelial cells in mucus that adhere to the corneal surface. These filaments are often painful and can move with blinking, further irritating the eye. Progressive disease may lead to severe complications, including corneal thinning or perforation. Band keratopathy is another risk, particularly in patients using glaucoma medications, leading to calcium deposition in the cornea. Additionally, chronic inflammation and surface damage can cause keratinization of the cornea and conjunctiva, reducing transparency and vision. Incomplete blinking plays a significant role in worsening pathology, as it limits the even distribution of the tear film and clearance of debris, promoting further damage to the already vulnerable ocular surface. Sjogren's syndrome can be associated with ATD and is diagnosed when ATD coexists with signs of systemic autoimmune dysfunction. These signs include the presence of hypergammaglobulinemia, collagen vascular diseases, or autoantibodies such as SSA or SSB. Approximately 10% of patients with clinically significant ATD are found to have Sjogren's syndrome. The underlying pathophysiology is believed to involve T-cell-mediated destruction of the lacrimal glands, primarily due to increased apoptosis of glandular cells. This autoimmune attack results in reduced tear production. Sjogren's syndrome can also affect other mucous membranes, particularly the salivary glands, leading to symptoms like dry mouth. The involvement of multiple body systems can significantly lower a patient's quality of life. The criteria for the classification of Sjogren's syndrome, shown in detail below, can be summarized briefly as follows. Diagnosis involves identifying symptoms of ocular or oral dryness, such as persistent dry eyes or dry mouth lasting more than 3 months, combined with at least 2 of the following objective findings: abnormal ocular tests, such as Schirmer test less than 5.5 millimeters or positive rose bangle staining, histopathologic evidence from a minor salivary gland biopsy, focus score greater than 1 per 4 millimeter squared, salivary gland dysfunction such as low unstimulated flow or abnormal imaging, or presence of specific autoantibodies, anti-Rho or SSA, or anti-LA or SSB. Primary Sjogren's syndrome is diagnosed when 4 out of 6 criteria are met or 3 out of the 4 objective criteria. Secondary Sjogren is identified when symptoms are accompanied by 2 or more objective findings. Certain conditions such as AIDS, lymphoma, graft-versus-host disease, head-neck radiation, or hepatitis C are considered exclusion criteria. Sjogren's syndrome is categorized into 2 clinical subsets, each with distinct characteristics and associated risks. Primary Sjogren's syndrome occurs in the absence of a defined systemic autoimmune disease and is notably associated with an increased risk of lymphoma, affecting approximately 5% of patients, with the risk accumulating over time. In contrast, secondary Sjogren's syndrome arises in conjunction with other autoimmune diseases, particularly rheumatoid arthritis. This form is more common and tends to involve broader connective tissue disorders, reflecting its systemic associations. Evaporative dry eye, EDE, is primarily caused by MGD, which impairs the lipid layer of the tear film and increases tear evaporation. MGD may be cicatricial, associated with conditions like trachoma, mucous membrane pemphigoid or atopy, or non-cicatricial, linked to seborrheic dermatitis, rosacea, or atopic disease. EDE is especially prevalent among individuals of Asian descent. The symptoms are similar to those seen in ATD and include a burning or foreign body sensation, eyelid redness, conjunctival injection, and filmy vision. Notably, symptoms are often worse in the morning. In EDE, several clinical signs help distinguish its presence and severity. These include seborrheic or eczematoid changes along the anterior eyelid margin and the presence of telangiectatic vessels with epithelial metaplasia. Changes at the meibomian gland orifices are also common and may present as foamy discharge, toothpaste-like secretions, posterior displacement, or margin irregularities. T-butt is often rapid, typically under 10 seconds. Additional signs may include papillary reaction, inferior punctate staining, pannus formation, and corneal scarring or thinning. A specific subtype known as non-obvious meibomian gland dysfunction, or NOMGD, refers to cases where the glands appear normal externally but secrete filamentous material only under forceful expression. NOMGD is considered a precursor to overt MGD. Diagnosing NOMGD involves gland expression using tools such as swabs, handheld devices, or manual digital pressure. This slide highlights several conditions that can mimic dry eye disease, often referred to as masqueraders. First is conjunctivochalasis, which is redundant conjunctival tissue that disrupts tear distribution and drainage, leading to irritation. Next, floppy eyelid syndrome. Here, the upper eyelids are abnormally lax and easily evert, causing exposure-related irritation and inflammation. Superior limbic keratoconjunctivitis involves inflammation of the superior limbus and adjacent conjunctiva, typically causing redness, discomfort, and a foreign body sensation. Nighttime lag ophthalmos refers to the incomplete closure of the eyelids during sleep, allowing the ocular surface to dry out overnight. Parkinson's disease can also mimic dry eye. It's associated with a reduced blink rate, which leads to increased ocular surface exposure and symptoms of dryness. Mucous membrane pemphigoid is a chronic autoimmune disorder that affects mucosal surfaces, including the conjunctiva. It can lead to scarring and significant ocular surface disease. Finally, limbal stem cell deficiency occurs when the stem cells responsible for regenerating the corneal epithelium are lost or dysfunctional. This leads to a compromised ocular surface, chronic inflammation, and symptoms that strongly resemble severe dry eye disease. Before starting treatment for dry eye, it's crucial to perform a thorough evaluation. First, rule out structural and exogenous causes that may mimic dry eye symptoms. This includes conditions like conjunctivochalasis, floppy eyelid syndrome, mucous membrane pemphigoid, and Parkinson's disease. These masqueraders can present similarly, but require different management strategies. Next, identify systemic conditions or medications that may be contributing to the symptoms. Common culprits include antihistamines, anticholinergics, and antipsychotic medications, all of which can reduce tear production or alter tear film stability. We also need to use caution when initiating treatment, especially in patients with evaporative dry eye. Some treatments, such as punctal occlusion, may actually worsen symptoms in certain cases. For example, in a patient with active meibomian gland dysfunction, blocking tear drainage can trap inflammatory secretions on the ocular surface, exacerbating irritation. For this reason, inflammation should be controlled before considering occlusion therapy to avoid worsening the underlying condition. This slide outlines management strategies for aqueous tear deficiency. We begin with tear substitutes. The choice of viscosity and frequency depends on the severity of dryness. More severe cases may require thicker gels or ointments. For moderate to severe dry eye, topical anti-inflammatories are key. These include cyclosporin A, available in 0.05% and 0.09% formulations, and lifitegrast 5%, both targeting T-cell-mediated inflammation. Corticosteroids can be used for short-term control in cases of severe inflammation. Under other agents, we have autologous serum drops, typically between 20 to 50%, which mimic natural tears and are used in severe ATD. Moisture chamber glasses to reduce evaporation, omega-3 fatty acids, though their benefit remains somewhat controversial. Acetylcysteine 10%, a mucolytic, is used specifically for filamentary keratopathy. Environmental modifications are also important. Patients should use humidifiers, avoid air drafts, and consider moisture chamber glasses in more severe cases. Lastly, smoking cessation is strongly recommended, as tobacco smoke worsens ocular surface inflammation and dry eye symptoms. And a final caution, avoid bandage contact lenses in ATD patients whenever possible. They carry an increased risk for infectious keratitis. Surgical management is considered for patients with moderate to severe ATD when medical therapy fails to provide adequate relief. A common surgical option is reversible punctal occlusion, which helps to retain tears on the ocular surface. There are two main types of plugs used: collagen plugs, which dissolve within a few days and do not fully occlude the canaliculus, can use transillumination to confirm presence or detect migration, and silicone plugs, which are visible under slit lamp examination and may remain in place for months or even years, though they can dislodge or migrate. Potential risks associated with punctal occlusion include canaliculitis, sterile inflammation, conjunctival irritation, and granuloma formation. In cases where intracanicular plugs are used and complications arise, surgical removal may be necessary. This underscores the importance of careful patient selection and monitoring when considering punctal occlusion as a therapeutic option for dry eye disease. Continuing our discussion on surgical management of dry eye disease, another option is permanent occlusion, typically achieved using cautery or radiofrequency under local anesthesia. This procedure seals off the puncta to reduce tear drainage. However, the canaliculi can sometimes reopen over time. Success is more likely in patients with low tear production and minimal ocular surface inflammation. Another surgical approach is correction of eyelid malposition, such as entropion or ectropion, which can worsen dry eye by disrupting tear distribution or exposing the ocular surface. These can be corrected with procedures like a lateral tarsal strip. In more refractory cases, tarsorrhaphy, either lateral or medial, can be helpful. Keep in mind, though, that lateral tarsorrhaphy may reduce the visual field and raise cosmetic concerns, so patient counseling is important. Let's now review the medical management of evaporative dry eye, which often targets meibomian gland dysfunction. Start with warm compresses, lid massages, and lid scrubs. Applying warm compresses twice daily for 3 to 5 minutes helps liquefy thickened meibom. This should be followed by firm, continuous eyelid margin compression, holding for about 4 seconds per area to express the gland contents. Lid cleansing is also important. Patients can use a washcloth, commercial pads, or gentle solutions like diluted baby shampoo or hypochlorous acid. Next, we consider topical antibiotics. Azithromycin, or sometimes erythromycin, is typically used in short-term or pulsed regimens. Azithromycin has a low risk of resistance because of its high minimum inhibitory concentration. Erythromycin carries a slightly higher risk. These antibiotics help by reducing bacterial lipases, which would otherwise degrade the quality of meibomian secretions. Lastly, topical corticosteroids can be helpful in the short term. These are indicated for moderate to severe eyelid inflammation, particularly if the cornea is involved. However, long-term steroid use should be avoided due to potential side effects like elevated intraocular pressure and cataract formation. Oral tetracyclines, such as doxycycline and minocycline, are commonly used in the medical management of evaporative dry eye, particularly for their anti-inflammatory effects. While they may not cure the condition, they help control symptoms effectively. Dosing typically begins with doxycycline at 50 milligrams twice daily, later tapering to 50 milligrams daily, while minocycline is often started at 100 milligrams daily. Lower doses are generally well tolerated and still beneficial. The usual treatment course spans 4 to 6 weeks, though it to be extended or used cyclically, for example, 3 weeks on and 1 week off, repeated monthly. In patients who are children or have tetracycline sensitivity, erythromycin can serve as an alternative. Omega-3 supplementation remains a controversial adjunct. Importantly, tetracyclines are contraindicated in pregnancy, breastfeeding, children under 8, and individuals with known hypersensitivity to these medications. This slide explains how tetracyclines, like doxycycline, benefit ocular surface health, particularly in conditions involving meibomian gland dysfunction and ocular surface inflammation. First, they work by inhibiting bacterial lipases. These enzymes are secreted by lid margin bacteria and break down meibomian lipids into free fatty acids and other irritants. These degraded lipids destabilize the tear film and promote inflammation, worsening gland obstruction. Tetracyclines suppress this lipase activity, leading to improved lipid composition and better tear film stability. Tetracyclines also exert broad anti-inflammatory effects by inhibiting several pro-inflammatory pathways. They reduce leukocyte chemotaxis and migration, lower production of reactive oxygen species, inhibit matrix metalloproteinases, especially MMP9, which can damage the cornea, and block phospholipase A2, thereby reducing the production of inflammatory lipid mediators. This wide-ranging anti-inflammatory effect is particularly useful in treating eyelid inflammation from rosacea and chronic meibomian gland obstruction.
New treatments for MGD focus on physically or thermally restoring gland function. Meibomian gland probing involves the manual opening of blocked ducts to reestablish secretion flow. LipiFlow combines controlled heat and pulsation to clear gland obstructions, although it is not typically covered by insurance and should be avoided in cases of active infection or recent surgery. The Cysteine Ilex thermal pulsation system is a handheld device that delivers heat alongside real-time eyelid compression. Another approach, intense pulsed light therapy, uses targeted heat energy to alleviate symptoms and potentially enhance gland function, though current clinical evidence supporting its efficacy is limited.
Rosacea is a chronic dermatologic condition that affects both the skin and the eyelids. It most commonly presents in middle-aged women, but it can occur in people of all ages and skin types. Notably, it's often underdiagnosed in younger patients. The pathogenesis isn't fully understood, but organisms like Demodex mites and bacteria may play a role. Rosacea is also linked to sebaceous gland dysfunction, and environmental triggers such as alcohol, spicy or hot foods, and stress can worsen symptoms. If the inflammation becomes severe, it can even lead to corneal scarring. On the face, classic signs include midfacial erythema, especially on the forehead and chin, episodic flushing, recurrent pustules and papules, telangiectasia, and in advanced cases, rhinophyma, thickening of the nasal skin.
Ocular rosacea is a manifestation of rosacea that affects the eyes and eyelids. Common eyelid signs include excessive sebum production, chronic blepharitis, and MGD. Patients often present with eyelid telangiectasia accompanied by hyperemia, as well as recurrent chalasia. Ocular signs include chronic conjunctivitis, stromal and marginal keratitis, sterile corneal ulceration, episcleritis, and in some cases, iridocyclitis. These symptoms reflect the inflammatory nature of the condition and its potential to cause significant ocular discomfort and visual impairment if not appropriately managed. The accompanying images illustrate classic features of ocular rosacea. The first photo shows facial involvement with acne, erythema, papules, and rhinophyma. The middle image demonstrates marginal keratitis with possible episcleritis. And the third image highlights corneal neovascularization and scarring, indicative of chronic inflammation.
Management of rosacea focuses on both dermatologic and ocular symptoms and typically involves a combination of systemic and topical therapies. The mainstay of treatment includes oral tetracyclines such as doxycycline or minocycline, which are effective in controlling both facial and ocular inflammation. For patients unable to tolerate tetracyclines, alternatives like erythromycin or azithromycin may be considered. Topical treatments, including metronidazole in gel or cream form and azelaic acid, are commonly used for managing facial rosacea symptoms. In cases with corneal involvement, topical steroids may be employed cautiously to address non-infectious inflammation. However, due to risks associated with long-term steroid use, such treatment should be closely monitored. In severe cases involving corneal scarring or neovascularization, surgical interventions like DALCs may be appropriate. PKPs, on the other hand, carry higher risks due to the presence of corneal neovascularization, thinning, and an overall compromised ocular surface. Blepharitis refers to inflammation of the eyelid margins and is broadly categorized into anterior and posterior types. Anterior blepharitis affects the front portion of the eyelid margin near the base of the eyelashes. It is commonly caused by seborrheic dermatitis, staphylococcus infection, or, less frequently, Demodex infestation. Clinically, it presents with symptoms such as eyelid redness, crusting of eyelashes, and accumulation of debris, scurf, and it is often associated with secondary conditions like hordeolum and chalazion.
On the other hand, posterior blepharitis involves inflammation of the inner eyelid, specifically affecting the meibomian glands. This type is most commonly linked to MGD. Clinical signs include thickened glandular secretions and telangiectasia of the lid margins. Posterior blepharitis is frequently associated with rosacea and evaporative dry eye, highlighting its importance in ocular surface disease. Seborrheic blepharitis is a chronic inflammatory condition that affects the anterior eyelid margin. It often overlaps with staphylococcal blepharitis, meibomian gland dysfunction, or seborrheic dermatitis elsewhere on the face or scalp. Patients typically report chronic eyelid redness, burning, and a foreign body sensation. On exam, key clinical signs include eyelid scaling, or scurf, which is usually oily or greasy in appearance, scaling of the lashes, eyebrows, scalp, and facial folds, turbid meibomian gland secretions, which reflect poor lipid quality, inferior punctate corneal erosions on fluorescein staining, conjunctivitis, which occurs in about 15% of cases, and evaporative dry eye, which affects up to 1/3 of patients. The image shown here highlights the typical greasy scaling at the lash base, classic for seborrheic blepharitis. Staphylococcal blepharitis is an anterior eyelid margin condition predominantly caused by Staphylococcus aureus. Unlike other forms such as MGD or seborrheic blepharitis, it features both an infectious and inflammatory component. It tends to affect younger individuals and presents with symptoms that are more severe in the morning but often improve as the day progresses. Patients commonly report burning, itching, and a foreign body sensation, along with noticeable crusting around the lashes upon waking. Clinical signs include fibrinous, matted crusts surrounding individual eyelashes, small anterior eyelid margin ulcers visible after crust removal, and telangiectasia with injection of the eyelid margins. Chronic or severe cases may lead to lash whitening or poliosis, lash loss or matarosis, or misdirected lashes or trichiasis. The included image illustrates classic crusting and redness along the lash line, a hallmark feature of this form of blepharitis. Demodex blepharitis is a commonly underdiagnosed eyelid margin disease caused by infestation with Demodex follicularum or Demodex brevis mites. It often presents in patients who do not respond to conventional blepharitis treatments. Key clinical clues include cylindrical dandruff or sleeve-like debris around the base of the lashes, along with symptoms such as itching, irritation, and lid margin inflammation. It is frequently associated with seborrheic and staphylococcal blepharitis. Diagnosis is typically based on identifying cylindrical dandruff and can be confirmed by epilating eyelashes and observing the mites under a microscope. Anterior blepharitis management centers on maintaining eyelid hygiene, including regular warm compresses and lid scrubs. Specific approaches vary by subtype. For seborrheic blepharitis, treatment includes hypochlorous acid sprays to reduce bacterial load and management of associated seborrheic dermatitis, for instance, selenium sulfite shampoo. Anti-inflammatory therapy is rarely needed. In staphylococcal blepharitis, topical antibiotics, for example bacitracin, erythromycin, and short-term corticosteroids may be used in selected inflammatory cases, while harsh scrubbing should be avoided. For Demodex blepharitis, tea tree oil treatments and daily shampoo for greater than or equal to 6 weeks, hypochlorous acid, and oral ivermectin in severe cases can help eradicate mites and reduce inflammation. This slide compares anterior and posterior blepharitis, including key features of the subtypes of anterior blepharitis. First, posterior blepharitis is synonymous with meibomian gland dysfunction, or MGD. In contrast, anterior blepharitis involves the anterior eyelid margin and can be categorized as staphylococcal, seborrheic, or demodicosis. Let's break down the differences. Location. All anterior forms affect the anterior lid margin, but demodicosis tends to involve the lash follicles specifically. Eyelash loss or whitening is common in staph, rare in seborrheic, and frequent in demodicosis, often with brittle or misdirected lashes. Crusting varies by type. Staph presents with hard, matted crusts or fibrinous scales. Seborrheic shows greasy debris. Demodicosis has cylindrical dandruff or sleeves at the lash base. Ulceration is occasionally seen in staph, but rare in the others. Conjunctivitis may occur in all types. Staph is often mucopurulent, seborrheic produces mild injection, and demodicosis may cause low-grade chronic conjunctivitis. Keratitis tends to be more severe with staph, including marginal infiltrates and vascularization. The others are milder but can still lead to punctate erosions or inflammation. Associated conditions include rosacea in both staph and demodicosis and seborrheic dermatitis in seborrheic blepharitis. Finally, key diagnostic clues. Staph, look for crusting and lash changes. Seborrheic, think greasy debris and facial involvement. Demodicosis, suspect if you see cylindrical dandruff, and confirm with lash microscopy for Demodex mites.
Now let's review staphylococcal blepharoconjunctivitis. This condition typically presents as chronic conjunctivitis lasting longer than 4 weeks and can be unilateral or bilateral. Patients often report burning, itching, discharge, and crusting of the eyelids. On exam, you'll find clinical signs that overlap with staph blepharitis. These include honey-colored crusts, ulcers, and injection along the lid margin. Discharge tends to be scant and mucopurulent, and tear film instability is often present. Clues to the etiology include the presence of honey-colored crusts in combination with marginal keratitis or conjunctival flectennials. Another important organism to be aware of is Moraxella leucunata, which causes angular blepharoconjunctivitis. This form is characterized by ulcers at the lateral canthus and a papillary conjunctival reaction. If the diagnosis is uncertain, cultures from the eyelid margin or conjunctiva can help guide treatment. When evaluating staphylococcal blepharoconjunctivitis, consider laboratory testing in cases with poor treatment response or uncertainty in diagnosis. In these situations, culture should be obtained, ideally after an antibiotic washout of at least 3 days. A positive culture typically shows heavy, confluent growth of Staphylococcus aureus. Susceptibility testing can be particularly helpful in cases that are resistant to first-line therapy, allowing you to tailor antibiotic selection. Here's a clinical pearl. If you encounter chronic, unilateral, and refractory conjunctivitis, you should broaden your differential. Consider cannuliculitis, conjunctival malignancy such as sebaceous carcinoma, or even a factitious disorder. Keeping these possibilities in mind can help avoid missed or delayed diagnoses in atypical cases. Marginal keratitis is commonly associated with staphylococcal blepharoconjunctivitis and presents with inferior or asymmetric corneal PEs or unilateral keratopathy. A classic sign is the presence of creamy white elliptical infiltrates near the corneal limbus, often at the 10, 2, 4, or 8 o'clock positions, separated from the limbus by a clear zone, though this may not always be observed. Management involves treating the underlying staphylococcal blepharitis and typically responds well to a combination of topical steroids, antibiotics, and good eyelid hygiene. However, if symptoms worsen or fail to improve with steroids, an infectious etiology should be considered. The accompanying image shows characteristic marginal infiltrates adjacent to but not involving the limbus. Plictennular keratoconjunctivitis is a hypersensitivity reaction, typically type 4, triggered by microbial antigens such as Staphylococcus aureus or, in endemic regions, Mycobacterium tuberculosis. The hallmark lesions, plictennules, are hyperemic, focal nodules that develop near the limbus on the bulbar conjunctiva or cornea. Clinically, these appear as small, round, elevated, gray or white nodules surrounded by dilated blood vessels. These lesions may ulcerate or undergo necrosis before resolving over 2 to 3 weeks. Conjunctival lesions usually do not scar, but corneal involvement can result in chronic inflammation, wedge-shaped corneal scars, neovascularization, and potentially even thinning or perforation if left untreated. Management closely mirrors treatment for staphylococcal blepharitis and marginal keratitis. It includes the use of topical corticosteroids combined with antibiotics, emphasizing meticulous eyelid hygiene. In areas with tuberculosis prevalence or relevant risk factors, TB testing should be considered.
The accompanying images illustrate the inflamed nodules and vascularization associated with plictennular disease. Plictennular keratoconjunctivitis is a hypersensitivity reaction, typically type 4, triggered by microbial antigens such as Staphylococcus aureus or, in endemic regions, Mycobacterium tuberculosis. The hallmark lesions, plictennules, are hyperemic, focal nodules that develop near the limbus on the bulbar conjunctiva or cornea. Clinically, these appear as small, round, elevated, gray or white nodules surrounded by dilated blood vessels. These lesions may ulcerate or undergo necrosis before resolving over 2 to 3 weeks. Conjunctival lesions usually do not scar, but corneal involvement can result in chronic inflammation, wedge-shaped corneal scars, neovascularization, and potentially even thinning or perforation if left untreated. Management closely mirrors treatment for staphylococcal blepharitis and marginal keratitis. It includes the use of topical corticosteroids combined with antibiotics, emphasizing meticulous eyelid hygiene. In areas with tuberculosis prevalence or relevant risk factors, TB testing should be considered. The accompanying images illustrate the inflamed nodules and vascularization associated with plictennular disease. Hordeola and chalasia are common eyelid conditions often linked to Staphylococcus aureus. A hordeolum presents as an acute, painful red nodule near the eyelid margin. External types arise from Zeiss glands or lash follicles, while internal forms originate from meibomian gland blockage. Most cases resolve spontaneously within 1 to 2 weeks. Initial management includes warm compresses to aid drainage. Topical antibiotics are generally unnecessary unless conjunctivitis is also present. Systemic antibiotics like doxycycline may be used for meibomian gland dysfunction or recurrent cases. Persistent lesions may evolve into chalasia, which are chronic, non-tender nodules. Treatment options include intralesional corticosteroid injection or surgical incision and curettage, preferred for larger or refractory lesions. Caution is advised with steroid use in darker skin due to potential depigmentation. Biopsy should be considered for recurrent chalasia to rule out meibomian gland carcinoma, especially when lash loss is noted over a chronic lesion. This concludes Chapter 3 of the Cornea BCSC book. I know this was a long one. Once you've taken a little break, let's move on to Chapter 4.